Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you remaining online past 75 minutes, your CE certificate will be emailed within hours of the completion of this talk, so be sure to check your spam folder. You are all muted, so no need to worry about background noise. We will have time at the end for questions, and you can submit questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at the following web address, elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. If you have a topic you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. As you can imagine, Silver Diamine Fluoride is still our most requested webinar topic. As we are now almost a decade into having SDF FDA-cleared in the US, we decided it was an appropriate time to touch base with two SDF experts and pioneers of its use and knowledge here in the United States. Over the next 90 minutes, Dr. MacLean and Dr. Jeremy Horst will walk us through the expanding science and discoveries, the do's and don'ts, the many different uses, myths, latest techniques, and much more. It's my pleasure to introduce you to these experts and our friends. I will begin with Dr. Jeanette MacLean. Dr. MacLean is a diplomat of the American Board of Pediatric Dentistry, a fellow of the American Academy of Pediatric Dentistry, owner of Affiliated Children's Dental Specialists in Glendale, Arizona, and mother of two. She received her dental degree with honors from the University of Southern California in 2003 and completed her specialty training in pediatric dentistry in 2005 at Sunrise Children's Hospital through the University of Nevada School of Medicine. Dr. MacLean has been an internationally recognized advocate and expert on minimally invasive dentistry, appearing in newspapers, magazines, television, and continuing education lectures. Most notably, she was featured in the July 2016 New York Times article titled "A Cavity-Fighting Liquid Helps Kids Avoid Dentist Drills," which brought national attention to the option of treating cavities non-invasively with silver diamine fluoride. Thank you for being here, Dr. MacLean. And now I'd like to introduce you to Dr. Jeremy Horst, who is the Director of Clinical Innovation at CareQuest Innovation Partners, an organization whose mission is to improve oral health for all. As a practicing pediatric dentist, biochemist, and educator, Jeremy is known for investigating the strengths and limitations of silver fluoride therapy, helping to develop smart fillings and accelerating the adoption of maximally effective, minimally invasive caries management techniques. In support of this work, Jeremy holds affiliations with the University of Washington and the Hayabus Dental Therapy Program. At CareQuest, Jeremy is driving the development of better treatments, preventives, and diagnostics to improve access to person-centered care, integrate oral health into overall health, and stop dental caries. And thank you, Dr. Keeper, for being here as well. Dr. MacLean, I'm going to turn it over to you.
Hi, thank you so much, Haley, and huge thanks to Elevate Oral Care for inviting me and my brother from another mother, Dr. Jeremy Horst. Hi, very happy to be here. So this is silver diamine fluoride after nearly a decade of use in the US. Of course, it's been elsewhere since 1970-ish. So what's the big picture? And that's really my goal, is to just take a big picture look at utilization of SDF and really how it's revolutionized the way that I'm able to deliver care to my patients, which is really exciting. Now, of course, we have evidence-based clinical practice guidelines, not only from the American Academy of Pediatric Dentistry, but also the American Dental Association. So this is real, folks. It's evidence-based. It's a great treatment option. And I think one of the big takeaways that I certainly have learned compared to how I was trained in dental school and in my pediatric residency is you don't have to drill everything. For example, here's a kiddo, one of the cases that I've shared many times and now have followed for 6 years, where they came as a second opinion looking to avoid IV sedation in their child that had failure to thrive, was teeny tiny little peanut, and they really didn't feel comfortable doing in-office IV sedation to treat the caries on asymptomatic caries on their primary incisors. So all we did was SDF. So you don't have to drill everything. And it's really neat to see him over the years and just the gratitude of the parents and the happiness of this child having atraumatic visits, happy visits. And here's the after. 6 years later, SDF only, we have nice, healthy, new, permanent teeth. Cutie pie. So yeah, the big picture is these as a pediatric dentist, of course, I'm seeing children, so that's the big picture to me is these kiddos. I don't have to sedate everyone. I don't have to bring everyone to the OR. I can do this simple, quick, effective treatment, even on front teeth. And then as the child gets older, more comfortable being in the chair, I can do conservative direct restorations if they even want it. And sometimes they don't. Like in their case, they were not bothered by the aesthetics, so SDF was all that we did. So that's really the big picture for me, is to be a firefighter first, controlling the biofilm, arresting and remineralizing caries lesions, and then you can be a carpenter second, where you restore the teeth as time, money, and behavior allow. Okay, like Smokey the Bear. One of my all-time favorite quotes from the great Dr. Nicola Inez is, restoring teeth without addressing the underlying problem is akin to replacing the windows on a burning building. I think it's so important for us as dental providers to realize and acknowledge that. And it's humbling. We're not curing people, we're helping treat their disease, but we need to look at it from this big picture perspective. And there's so many benefits to silver diamine fluoride. And honestly, the more that I used it, the more that I saw the benefits to patients. Of course, improving their oral health is the ultimate goal. Improving outcomes, reducing emergencies. There's studies showing fewer emergencies when kids are treated with SDF. Reducing hypersensitivity, reducing the cost of care for individuals and especially for our Medicaid system, increasing access to care and delivering individualized patient-centered care. There's lots of benefits to providers. For me, it's helped increase my patient retention. We see a lot more internal marketing, reduce stress. It's much easier to paint a treatment on a child's cavity, especially when they're a moving target, versus having to do sedation or administer local anesthetic, especially with those helicopter parents. Improve satisfaction, reduce overhead. And I think a big misconception is we're still very productive. In fact, our hourly production has increased ever since we've introduced minimally invasive treatment options. Another big picture item is, this is part of informed consent. The risks, benefits, and alternatives to treatment, including no treatment. So if SDF is a clinically viable treatment option, and not every tooth is a candidate for SDF, the way I like to explain it is sometimes we're too late to the party and the caries is already pulpally involved, or there's infection, etc. But when it is an option, we should be offering it to our patients, and we shouldn't be making assumptions as to whether or not they're going to want it. Let them decide. Give them options. Let them decide. And when you look at studies of when it is actually offered, the majority of parents, when it comes to accepting this for their kids, the majority do prefer SDF, especially as an alternative to advanced behavior guidance options like sedation. And that, of course, was the example in the New York Times article with this adorable little boy who the mom is a medical anesthesiologist, and she chose SDF over sedation for her child. So don't assume, just give options. And here's one of my oldest patients, is my office manager's mom, who had horrible root caries, hypersensitivity, and we did SDF, and she reported a night and day improvement in her symptoms. And again, don't assume that they're going to reject it because of potential color change, but she has all these metal collars already on the posterior teeth with these crowns, so just give them the option. And speaking of SDF in older patients. Again, I'm a pediatric dentist, so is Dr. Horst. So I do give a lot of examples of that, but there's great resources on using SDF for older patients, like this great book that you can get online, dentaloutlook.com.au. There's a recent webinar that Elevate Oral Care hosted, and it's archived on their YouTube channel. All right, so the next big ticket item, or the big picture, is keeping it simple with applying SDF. And that's really the beauty of this treatment option, is it is that simple that you could literally do it just with no running water, no electricity. This t-shirt really sums it up. Dry, apply, and say goodbye, which is one of my favorite quotes from my co-speaker here, Dr. Jeremy Horst. And this is Haley and I, where she gifted me with a shirt. I love it. So yeah, just dry, apply, and say goodbye. It's as simple as that. Don't overcomplicate it. It's not necessary. They've updated the package insert to help clarify that. You don't have to air dry the SDF after it's applied. You shouldn't be rinsing it off. You don't need to light cure it. It's as simple as that. And there's lots of formats that you can now get Silver Diamine Fluoride. Of course, here's the old school original bottle, and then they switched it to the black bottle. There's unit dose. There's now these little mini dose bottles. And the newest innovation is the gel form, which is nice because then you don't have to worry about it dripping or running. But yeah, use whatever you like. And I do have resources on YouTube on basic application techniques and tons of other techniques. And there just is not enough time in this presentation to go over it all, but please use this as a resource for you or your team. And I also send parents and patients to this so they can see how it's done and how simple and painless it can be. You know, there's still lingering confusion over the certain marketing of products, you know, like white SDF or non-staining SDF. The reality is there's no such thing as a non-staining SDF. Adding potassium iodide, it can help reduce discoloration, but it doesn't eliminate it. But more problematic, it also reduces efficacy. Like the study showed, the teeth treated with KI were more likely to be pulpally involved after 12 months. So I don't recommend bothering with it. Other issues with other products is the pH can be very high, which can lead to soft tissue burns, and you can still see staining. So remember to keep it simple. Newer confusion is like now there's this option of Curadon, which is a peptide that helps do guided hard tissue regeneration, which is a great option, and I use it now, but it's not replacing SDF. They're both great options, and they have different indications. So when would I choose SDF? Well, for starters, a cavitated lesion, you can't use Curadon on an already cavitated lesion. It's not even an option. So you're too late to the party. Primary teeth, so kids that are too young or uncooperative, you know, they perhaps can't tolerate the isolation or the etching needed to do the 5-minute procedure for Curadon. We don't want to burn their skin with etch on a moving target. Now let's say there's permanent teeth not in the spile line and the posterior, again, offer the SDF. And there's a lot of patients, including myself, that have no problem with it in the back teeth. MIH, hypersensitivity, SDF is amazing for that. Root surfaces, exposed dentin, and a big factor too is the cost. You know, SDF is incredibly affordable. You can get it as inexpensive as 50 cents a drop, compared to like one vial of the Curadon is $30. That's a big difference. If you want to learn more about that, I recommend this other great webinar from Elevate Oral Care, and it's archived on their YouTube channel, talking more about Curadon. I love SDF, but you know, it's not a cure-all. It's just a treatment, a non-invasive and non-surgical treatment for caries. And different sites have lower or higher risk of progressing even with SDF treatment. So it's really important for people to realize that as part of the big picture. So how open a lesion is to brushing away the biofilm or being open to the flow of saliva for natural remineralization. That really is the big picture of which teeth are most likely to arrest with SDF treatment alone. And I think that this visual aid from from Dr. Graham Craig is a really good example of that, especially for providers to realize that everything they treat with SDF is not going to arrest. So knowing which ones are more likely or less likely to. So open lesions have the lowest risks of getting worse. Occlusal surfaces, medium, you could seal it with glass ionomer. Of course, you have direct access. But proximal lesions, non-cleansable lesions, are the most likely to continue even when you do apply SDF. Not all of them do. You know, if behavior changes, if hygiene improves, diet improves, you can still get proximal lesions to arrest, but it's not 100%. Case selection is important. You know, not every patient is a good candidate for SDF. This is from the British Dental Journal, and I like that they pointed out the fact that a contraindication would be a person that's not able or willing to brush or unlikely to, or patients or parents unable or unwilling to take responsibility. So for example, in my practice, if I have something that's not good with follow-up or reapplication, they are demonstrating to me that they're not a great candidate for this option, especially if they have proximal caries, because those lesions can in fact get worse. That being said, there are some patients who maybe aren't able to take care of their teeth due to medical reasons, stroke, et cetera, or patients in hospital settings, nursing homes, group homes, where maybe they can't take care of their teeth to the best of their ability, but SDF can in fact have a dramatic impact. So I really like the option of having, for example, dental hygienists that can go out in the field and do this treatment for patients. So this is a great paper looking at that from Texas A&M, where SDF was applied to geriatric patients with gingivitis living in senior retirement homes. And there was significantly less gingival inflammation, less plaque, just from applying the SDF. So the results of that were quite impressive. So depth of the lesion is a big misconception with SDF. You know, I use SDF in deep lesions probably daily. So really only irreversible pulpitis is the only true clinical contraindication to SDF. But you can arrest, remineralize, and desensitize teeth before you actually drill them. So I recommend not, you know, just remove the plaque, but you don't have to remove any caries before applying SDF. And I think of it like recycling, because that surface might actually remineralize and become harder, and you can use that as a base to your restoration if you're going to do one. More conservative tooth preparation is favorable to the pulp. And I can't emphasize this enough, complete caries removal is not necessary for caries management, which is the polar opposite of what I learned in dental school and residency. So, and I feel like a lot of my colleagues struggle with this. So I recommend revisiting the literature, because we've really known for more than a decade that complete caries removal is not necessary for caries management. The seal is the deal. So for example, in lesions such as this, you might have this mushy caries, or what we call the necrotic zone. And quite frankly, it doesn't matter how much SDF you put on this is not going to remineralize because it's the necrotic zone. That doesn't mean the SDF didn't work. It just means that this portion of the lesion is necrotic. But deeper portions are contaminated zone, the demineralized zone. You can in fact arrest and remineralize this, and it can become hard as a rock. So it's not necessary to drill all of this out, because you might accidentally mechanically expose the pulp, or you might heat it up, and you might become the problem that triggers that irreversible pulpitis. So we don't want that to happen. So silver diamine fluoride and glass ionomer are what we call SMART, which we'll get into a little bit more. It can help remineralize these caries lesions in the dentin, so it's not necessary to drill that all out. So you're going to reduce the amount of tooth structure you're removing. You can reuse it by remineralizing it. So again, it's just this concept of recycling that. And there's a growing body of evidence to demonstrate the safety and efficacy of using SDF on deep caries lesions, like this paper in the CDA journal that treated almost 300 adult teeth with silver fluoride. And it helped to reduce the number of those teeth that ended up needing root canal therapy. So yes, you can use SDF in deep lesions. But it is not a cure-all. So in cavitated non-cleansable lesions, especially proximal lesions, we do want to make sure that we're reapplying it. I recommend to restore cavitated non-cleansable lesions when time, behavior, and money allow. So for example, this is a cavitated proximal lesion in a primary molar where only SDF had been applied for 2 years, and eventually that tooth did in fact abscess. So I just want to make sure that people understand that it's not a cure-all, but it is a wonderful option with many, many benefits, but we do need follow-up reapplication. And in some cases, like what we already mentioned, these proximal surfaces that are more at a high risk of progressing despite SDF application, we need to keep an eye on those and either restore them, or another option, you could do non-restorative caries treatment where you open or disc the proximal contact to make it cleansable. I mean, even that's an option. Now, in terms of billing, we want to be aware of the fee. I try to keep it low. It's similar to our fluoride varnish code, or excuse me, our fluoride varnish fee. It is per tooth. Frequency, we know from the literature that at a minimum, we want to reapply it at least every 6 months to unrestored caries lesions. Now, let's say you're doing it just for hypersensitivity, you can apply it as needed. You don't have to do it every 6 months, but if we're talking about caries, unrestored caries, the clinical trials have demonstrated that you want at least a biannual reapplication. And you'll hear different recommendations and different protocols that different folks use, but at a minimum, you want that every 6 months. Now, in terms of coverage, more and more insurance plans are covering it, more and more Medicaid programs are covering it, but it's really important as a provider to be aware of the limitations, and in particular, the waiting periods that could be placed on restorations. For example, there's some insurance plans where if you bill out SDF, let's say you're doing SMART and you bill out SDF and then turn around 2 weeks later and want to bill out a restoration code, they might not cover that restoration code. So you just have to be aware of it. You could no charge the SDF. If something is not a covered benefit, you could charge the patient for it. There's different ways to address this challenge, but most important thing is I want people just to be aware, because I feel badly when I see folks that are complaining online that they were surprised that, for example, a filling was denied by the insurance company. So just be aware of that. Read the description of benefits, and there's some workarounds for it. Now, as far as the SDF code, 1354 is the caries arrest code, so interim caries arresting medicament application per tooth. A newer code is 1355 for primary prevention, caries preventive medicament application per tooth. So that's an additional code. It doesn't replace the 1354, and you still need to be aware of the coverage and limitations, and they're both intended to be per tooth. So a little more on 1355 and SDF for primary prevention. There's a little controversy in this, particularly from the perspective of just trying to describe SDF as a sealant, because it really isn't a sealant, meaning a fissure groove, even if it's treated with SDF, which is great, and I do it, it doesn't make that surface smoother. You can still trap food and plaque, biofilm, and caries could progress over time. So it doesn't technically make that a smoother surface. And if we're doing it on teeth that perhaps have decalcification or immature enamel, hypomineralization, et cetera, you could potentially have stain. So I just would use caution in trying to explain it as a sealant. Also from the perspective of insurance companies, because I've seen some that think of it as a sealant and then they want to only reimburse it once every 3 years, when I know I need to be reapplying it every 6 months if it's a non-cleansable or cavitated lesion. And the AAPD has come out with 2 statements cautioning against that primary prevention code, specifically using it in children. So I just want you to be aware of that. This is, I think, a fantastic example of 1355 and how effective SDF can be for primary prevention, particularly on root surfaces in older patients. In fact, it was literally the cover photo or cover article in the ADA journal back in 2018. So this would be a great utilization of 1355 primary prevention with SDF. Now, you may have seen this paper that was recently published by, or study, I should say, published by NYU, the Carried Away clinical trial. And you know, I absolutely support the use of SDF to help increase access to care. I fully support our auxiliary, you know, or dental hygienists being able to go out in the field, dental schools, nursing homes, et cetera, to be able to increase access to care and utilize SDF. I 100% support that. But I think we still need to keep in mind that big picture that SDF is not a cure-all. It's not a one and done treatment. It needs to be reapplied. It needs follow-up. Cavitated lesions that aren't cleansable would benefit from a restoration. So that's my biggest concern with the messaging that came out from this particular trial. You could say they got carried away. Never have I ever seen a media blitz quite like the PR campaign following this one paper where they just applied SDF one time. And this was like the general messaging: 3,000 kids, one application, 80% of cavities, which sounds fantastic, but you know, I don't want to mislead people. And if you really look deeper into exactly what happened in this particular trial, is no radiographs were taken. The returning patients that had SDF actually were only 20% of the original 3,000 pool of patients, despite the fact that there were actually more kids in the SDF group to start, but then at the end there were significantly less. So really only 61% of the SDF only treated group, meaning they only had it one time and then came back 2 years later. Only 61% of those kids came back in the SDF group. So, you know, where did all of the SDF treated patients go? Anyone like me treating kids post-pandemic, we know what happened. Like if you're only putting SDF once with no radiographs, especially if there's proximal or cavitated non-cleansable caries, it could be like this example. This is a colleague of mine who posted this case earlier of a patient with pain and an abscess primary molar due to proximal caries that, you know, initially you can't see that clinically, right? You can see it radiographically. And it's just frustrating. So I don't want to deny access to care. I fully support school-based oral health programs, but you know, we do need to take radiographs. We do need to reapply SDF or restore cavitated lesions, or at least make them cleansable, or you can run into this scenario. So without seeing what's really going on behind the scenes, and mind you, now the permanent tooth has caries, you know, you can't see this with the naked eye until it gets to the point where the kid's in pain and the tooth is abscessed and we're extracting it. So I don't want that to happen. Yeah, because without x-rays, yeah, sure, it looks great. But no, we need to know what's going on. And I love applying SDF proximally. I do it probably every day in my practice. So it is a great treatment option, but it needs reapplication, and it needs to be monitored, reapplied, and restored if those proximal lesions get worse. So as far as the proximal application, I would say when I initially started applying it, I used the floss routinely. And now this is a more recent paper published in the AP journal that question, you know, do we really need to have the floss? If you dissect this article, ironically, the teeth that weren't treated with the floss actually had no opposing tooth. Well, we already know that open lesions are the most likely to arrest. And the ones that had the highest rate of arrest used the microbrush and the floss, but they only looked at 4 teeth in that category, so they dropped that. But anyhow, I just think it's great that this is helping to increase awareness of the option to use SDF on proximal lesions, because you certainly can, and it is quite beneficial, especially with kids, because I see tons of proximal caries lesions. So in terms of the evidence we have for using the floss, we have my retrospective analysis with Ohio State University using floss, covering the lesions with varnish afterwards. This paper from the 80s from Japan that utilized floss to apply SDF to proximal caries lesions. And of course, the OG himself, GB Black, used silver nitrate on silk floss to apply it to proximal caries lesions. But I'd love to see a paper that had a better design to really see if it's necessary. And what I'm finding more frequently now, especially if the kid is real wiggly and it's a miracle that I just was able to isolate and dry off the teeth, I will just saturate the contact area with my microbrush and the SDF and allow it to absorb for at least a minute, and then cover that area with fluoride varnish. So you can apply it proximally. Do we need the floss? Maybe we don't, and that certainly would make it easier. Some unintended consequences that I've seen from our evidence-based clinical practice guidelines are that because those studies included in the papers only looked at cavitated lesions, some people then think you can only use SDF on cavitated lesions, and that's not true. I use it on non-cavitated lesions, just it being an incipient lesion or porous, or let's say it's just hypomineralized and hypersensitive, or it's a non-cavitated root surface. Even that will be efficacious and can help to arrest caries or decrease hypersensitivity. So this is a great image from Dr. Gabriel Domenici showing how, this is just porous. It's not cavitated, but absolutely that SDF is getting in there. But again, there are surfaces that will be less likely to arrest with SDF alone. So we need radiographs, we need reapplication, we need to restore them if they're cavitated and non-cleansable. So I have so many examples of this in my practice with patients where they had proximal caries lesions, and especially with good follow-up and behavior change, good home care, good diet, you can arrest these proximal caries lesions. So here's an example with a nice long-term follow-up where all we did was SDF to those proximal lesions as an alternative to sedation and conventional surgical restorations. And here she is with the teeth starting to exfoliate. And it's just neat to look at these. I applied it with a microbrush and floss. It kind of looks like a liquid filling. It's getting in there. But it doesn't always work. Here's another example on an admitted non-flosser where over time, 2 of the 8 proximal lesions got worse. So I restored them. I just did simple class 2 RMGI fillings, and still, the big picture is this child was older, more cooperative, used to me doing things in their mouth. They didn't have to be sedated. I just did the conservative little class 2 fillings, and we still have a happy camper. So there's where it succeeded. There's where it was unsuccessful. So I moved to doing restoration. So as you're monitoring these proximal lesions, if you see them getting worse, I would recommend to either place restorations. You could do fillings, you could do Hall crowns, you could even do non-restorative caries treatment and just open the contact and make it cleansable. So lots of options. SDF for molar incisor hypomineralization. This has definitely revolutionized the way that I'm able to manage these patients, because it can dramatically reduce the hypersensitivity, get these kiddos comfortable, stabilize the teeth until they're older, and we can decide what are we going to do with these teeth from a restorative perspective. And of course, some of these are just quite minimal, where I could treat them with SDF to desensitize them and place, this is a high viscosity glass, or I should say glass hybrid, to seal the fissured grooves and protect them, or what we call smart technique. Or in these more severe cases where it's really in bad shape, where I just want to get this kiddo out of pain. So using SDF, placing the glass ionomer can help stabilize them, get them comfortable, get the soft tissue healthier, while that family decides what to do long-term. So whether it's extraction and second molar substitution or restoring it, let's say with a stainless steel crown, this is really an amazing new option that we have that I didn't have when I started out 20 years ago. So look at how the soft tissue even is so much healthier now that this is stabilized. Some tips from MIH, just be aware of the hypersensitivity and be really careful when you're cleaning and rinsing those teeth. When you isolate and dry them, I would just use gauze to dry them versus using compressed air because you don't want them to jump out of the chair. And just anecdotally, some patients have reported some discomfort when the SDF was applied that initial or first time. Not everyone, some do, and some might need it applied multiple times to achieve the desensitization. That being said, I've had patients where we just applied it once and literally within the same appointment, the hypersensitivity was gone. If you want to hear more about that, we have this webinar with my co-speaker, hello, that's free to view, archived on YouTube on Elevate Oral Care's channel. Lots of great lectures on there. So I'm really grateful to Elevate Oral Care for providing all of this great free continuing education. So some pitfalls with SDF would be poor case selection, meaning like you're too late to the party, poor follow-up, like you're putting it once and thinking that's all you have to do, not adequately isolating or drying off the teeth before you apply it. If the patient or parent is not on board with behavior modification, nothing we do is going to succeed long-term, or having like a cure-all or one-and-done mentality that can sabotage you because you're really not understanding the caries etiology. And then delayed placement of a sealed restoration, which could be smart or Hall, or I also mentioned just making the lesion cleansable. In cavitated lesions that are not easily cleansed or open to saliva, you could end up with those examples like the abscess teeth that have to be extracted. And in terms of considering restoring the form and function and aesthetics of SDF teeth, just remember that not every SDF tooth requires a restoration, like some of the examples I showed you earlier where we just did it on incisors and that's all we had to do because they weren't focused on aesthetics. But use your best clinical judgment, look at their calendar age, the dental age of the patient, if it's a child or an adult patient. You know, just see, let's say you're putting it around a restoration margin. You can monitor that. How cleansable is the lesion? Look at other associated risk factors, like could the tooth fracture if you're not restoring it? How's their behavior? You know, would they need sedation if you had to restore it? Maybe you need to buy time. And then, of course, the patient or parent's preference. And SMART is silver modified atraumatic restorative treatment, or SDF to arrest and remineralize a caries lesion, and then a glass ionomer restoration to restore and actually further remineralize the caries lesion. And this is an example of Twostep Smart, where SDF was done initially to stabilize the lesion, and then when the child was more comfortable in the dental chair, I was able to place the glass restorative. Even just separating this out by about a 1 to 2 week period, there will not be lingering free silver ions, so your restorative material will stay white. Even in this case, I didn't pick up a handpiece. There was no prepping of the tooth whatsoever because it's not necessary. And I just placed the glass ionomer and you have a nice aesthetic, durable restoration. This is that tooth 2 years later. Looks as good as the day I placed it. This was built out as an occlusal composite, and we have tons of literature demonstrating the efficacy of single surface atraumatic restorative treatment. And then here's 3 years later, the tooth is getting ready to exfoliate. 4 years later, we have a nice, healthy, new permanent tooth. So big picture, this is a really great option. If you want to learn more about SMART, we have this another great resource from Elevate Oral Care. You can watch this pre-recorded webinar on SMART technique on YouTube. Now, with respect to Hall technique or even atraumatic restorative treatment, you absolutely could use SDF. It's not necessary for the proven efficacy or art or Hall technique, but a lot of us like to think of it as the belt and suspenders. It can also help you buy time. It can help assess the pulp status. It can help improve outcomes. Like, for example, this particular tooth, to me, I wasn't sure that it wasn't already pulpally involved, but the patient reported no symptoms. So this was a way that I could help assess the pulp and buy time by placing SDF and glass ionomer and then reassessing the tooth a month later. Still asymptomatic, so then I placed a Hall crown. And that's all that tooth needed. That tooth's getting ready to exfoliate now as well. So another great option. I have so many cases like this. If you follow me on Instagram at Dr. MacLean, I like to post those cases there. And as far as billing, this is a frequent question, big picture question that I get. My recommendation is bill what you do. Maybe that could be the new dry, apply, and say goodbye t-shirt. So, we don't charge by the hour. It's on the procedure accomplished. So I warranty it as you would any other conventionally placed restoration. And the clinical trial evidence demonstrates that ART, SMART, and Hall technique are equivalent, if not superior to conventional surgical interventions. So why would we value it any less? So, if it's something where truly it's interim, meaning I'm trying to stabilize the tooth until we do something down the line, this I'm billing out as ITR or the protective restoration. Now, if it's definitive, like a single surface ART restoration or single surface SMART, I'm billing this out as the occlusal composite code, or for example, a Hall crown, that is the stainless steel crown code. I don't know how quickly I went through that, but thank you. That's it from my portion, and now I'll hand it over to my buddy. Oh, and big thank you to the founding fathers of SDF in the U.S. So Mike Shercliffe, Peter Milgram. This is a great group of friends. Steve Duffin, John Fricella, our friends at Elevate Oral Care. Our next speaker, Dr. Jeremy Horstkeeper. But thank you to you guys for helping be a part of this journey that is revolutionizing the way that we can deliver care. It's exciting.
Beautifully done, Dr. MacLean. Beautifully done.
Thank you.
I will wait for our friends at Elevate to switch over. Oh, there we go. Boom. And here we are. What fun. So really, Dr. MacLean, thank you so much for that. As the founding mother of SDF in the US. The others of us are founding fathers, then you must be the founding mother.
I like it.
But it's an honor to be on here with y'all, and I echo the great gratitude that I and the community have to elevate oral care and Advantage for bringing us Silver Diamine Fluoride, for increasing the level of understanding of oral health throughout the US and beyond, through webinars like these, through the recordings on elevating care, the elevating care portion of the elevateoralcare.com website. I'm very grateful. It's a huge resource that a lot of people are using. If I think about, where SDF is now, 8 years, really 9 years after it got cleared by the FDA, 8 years since we've had a product, it is typical for me to be at a playground and get into a conversation with somebody, find out what their passions are, maybe what they do for work, and then the question turns around, what do you do? And they figure out that I work on introducing non-invasive therapies for dental caries, and we start, use SDF as an example, as the flagship, really. They will drop whatever they're holding and hug me in gratitude for how much of an impact this has made on just their life, their child's life, their elderly mother's life, whoever it is, that their disease is able to be controlled, that they were able to avoid, that they were able to access care for dental caries, that they were able to have less invasive care because of this tool. I literally get hugs, I don't know, once a month for the work that I do on SDF, not in a clinic, not in a dental setting. And so I think that's a statement of where this is. And so hopefully through the next few minutes, giving a little bit of a presentation here, I'll be able to share why that is, where we are, and add a little color to the beautiful presentation that Jeanette gave. So a little background on myself. I am Director of Clinical Innovation at CareQuest Innovation Partners, as mentioned earlier. Innovation Partners exists to validate and scale transformative solutions to improve oral health for all through these 6 modes of action. And my group really runs the validation component, as I'll share. I need to disclose that we do have financial and or investment relationships with companies that commercially market minimally invasive care related solutions. Although, you know, not yet SDF, but a competitor. So I need to disclose that. We at CareQuest, in the enterprise of CareQuest Institute, CareQuest Innovation Partners, see these non-invasive therapies for dental caries as incredibly important to empower improved health outcomes by improving access, costs, experience, and disease management. Jeanette mentioned these things as well, and it's, you know, it's not just us pediatric dentists who are, you know, establishing the cutting edge of these therapies that believe this. Now, really, institutions have gotten behind this and are promoting this, as I'll explain as we go through. But this is the CareQuest Institute, which is the largest oral health institute in the United States. We believe in this. And so we believe that this can be done, and it is done in mobile and portable dental settings. It can be done by non-dentist providers, and that's one of the main arguments that I'm going to be making, is that this is now being done by medical providers, and we have a medical billing code for this that's going to start being reimbursed and activated July 1st, 2023. So just a few weeks from now. And that study Jeanette mentioned, I'll make this point again later, one of the big so what's, the carried away study, where the outcomes, you know, leave you scratching your head a little bit, but the utilization, the fact that it was done, it was dental hygienists and school nurses doing SDF in schools throughout New York City. Get back to that. So that's why this is important, is that these people don't need to go, you know, for their first line of therapy, for their first step in getting their caries disease treated. They don't need to go to a dental clinic. Now, like Jeanette said, we all believe they should, but a lot of folks aren't. So this is an important first step in therapy. Lower costs, just the materials cost less, the techniques take a shorter amount of time, and frankly, people who are not paid as much money as dentists or dental specialists are can provide these. So that leads to cost savings for whoever's paying for this treatment. And what I'll show later is you can actually increase your profitability also, as Jeanette mentioned, because they're so much shorter and lower paid workers are doing this. So you can actually increase profitability for the clinic that's doing this, and simultaneously decrease costs for the payer. So that's a huge win. The experience is why I get the hug, right? Instead of you know, what we had of dentistry, you know, 60 years ago, 40 years ago, 20 years ago. Now what we have is that we can treat dental caries without needles and drills. Now, can we do that completely 100%? No. You know, what's the only definitive procedure we have in dentistry? Extractions, right? None of the restorations are definitive. Permanent? Definitive? No restoration lasts forever. Maybe like Tucker gold inlays and onlays. You know, a lot of those seem to last forever, but that's nobody does those anymore, except the Tucker Club up in Seattle. And if you do, bless you, please keep doing them. But disease management will make that case over and over again. But so we at CareQuest are helping to join the team like Elevate in establishing the set of non-invasive therapies. And we have seen this work profoundly well in clinics. This does not represent a fringe movement. So if you look across the entire nation at non-invasive therapies like SDF, like the D1354 code that Jeanette mentioned and the 2940 code that Jeanette mentioned, if you look at the utilization of those codes compared to minor restorations, about 4 years ago, it was about 1 in 50 teeth were being treated with non-invasive treatments as compared to minor restorations. As of 6 months ago, it was 1 in 12. So across the entire country, this represents commercial and Medicaid, represents 80 million lives, largest data set that we know of in the United States for dental care. 1 in 12 teeth is being treated with a non-invasive therapy with respect to minor restoration. So this isn't uncommon. This is a logarithmic chart, by the way. If you look at the vertical axis, that's 1 in 100, that's 1 in 10, that's 1. So, you know, if you put it on a linear axis, it'll be 2. And if you look at clinic systems, large clinic systems, so Advantage Dental Plus has about 92 clinics right now across 8 states. What you see is that they were poised to, they were already doing non-invasive treatment routinely in their clinics, but they were still doing more restorations. And when the COVID pandemic hit, and they had to shut down, and then they reopened, and they had the buildup of need, they were trying to avoid aerosols in 2020 and reduce them thereafter. They very quickly started doing more non-invasive treatments than invasive treatments for dental caries. And so after things, sort of completely reopened for these clinics, we worked together with them. We at CareQuest Innovation Partners worked with the great Charity Ludwig, another one of the godmothers of SDF in the United States, or founding mothers, and Tess Bruner at Advantage, and others, lots of other wonderful people, to get this back up. And now they're doing more non-invasive treatments than minor restorations, where they're managing a population of almost 500,000 people, adults and kids. So this is not the fringe. This is happening. This is the future and the present. Jump on board. If you're not yet, come with us. A little bit about SDF, how it works. I like to do mechanism stuff. I am a scientist, and I like to play in the lab. It's been a little while, but one of the things that we did once Elevate gave us Silver Diamine Fluoride was that we started looking at teeth that have been treated with SDF and then exfoliated, like what Jeanette showed, or they were treated with SDF and they were extracted for orthodontic purposes. We pulled them out and put them into the fanciest microscanners that we have on the planet. And what we saw is that SDF hardens carious enamel and dentin. Well, you can know that clinically just by looking at it, by using a non-pointy probe or even a pointy probe. Don't do it, but people do it. And what we saw is that the silver reinforces, it coagulates the exposed protein from bacteria and dentin, and it fills a lot of the microvoids with solid silver. In the case of going into dentinal tubules, those are microwires. And so it can, and often does, when it's arrested, it does, dramatically harden the lesion. Now, is that a permanent solution? Jeanette talked through that beautifully. So a lesion like this, here we go, you would typically seal that with the glass ionomer. SDF first. If you want an aesthetic result, do a tube visit, and then seal it with glass ionomer. That's what was done here to this permanent tooth that was extracted for orthodontic reasons. On the right, we have existing science from Australia, which we really love, showing how SDF works as an antimicrobial. And so it basically, these are slices of dentin that have been soaked in strep mutan soup with a lot of sugar and strep mutans for a week. Keep adding sugar, keep feeding the strep mutans, and the green is alive and the red is dead. So we can see is on the left side there is that the living bacteria pre-SDF treatment, take the dentin out, rinse it a little, put some SDF on it, let it soak in for a minute, rinse it a little, put it back in strep mutan soup, and the bacteria are killed throughout, and eventually they reinvade from the top, but much more slowly. So on the green, this is after a week in sugar and strep mutan soup, and then on the right, this is also after a week in after an additional week in sugar and strep mutan soup. So it prevents the regrowth of bacteria incredibly well, but not perfectly. It's not 100%, right? So eventually you have to either, improve the diet, improve the hygiene, keep putting SDF on a whole bunch, or seal it. I think those are really the options. That if you keep having the disease factors, then eventually, of course, the disease is going to come back, because the only definitive treatment we have in dentistry is an extraction. So I wanted to talk through this slide a little bit. So this gets to one of the points that was being made there, is that if you apply SDF enough, it seems to be able to arrest everything. But is it practical? Well, in some cases, absolutely, and in some cases, absolutely not. So this tooth on the left, this tooth L, this cavitated caries lesion on the distal of L, is exactly the kind of tooth that I would say that is not going to respond to SDF. That will not work. But Dr. Peter Vianos got it to work. How do you get it to work? He put SDF on 5 times in the first 3 months. 5 times. Now, Dr. MacLean, we can ask this later when we bring you back on, can you do that typically for a patient who's coming to your practice? Like, I don't think so. But maybe that was the best option for that patient. Maybe if there's someone in a nursing home where there's no dental services that are coming to them, can the nurse put SDF on 5 times in 3 months? Maybe that is the best and most convenient therapy to arrest and treat, arrest the lesion, treat the disease. Maybe so. There are situations like that for sure. In typical dentistry, is that the most convenient? No, right? So that's where we combine with sealing the lesion. So this is the balance that I wanted to try to think through, is that in different situations, there will be different approaches that are most efficient for the patient and provider team. So a little bit about SDF validation. Again, there's some overlap with what Jeanette brought up, but I wanted to highlight a few amazing steps of progress that we've all made together. And this is the first biggest one, really, is that the World Health Organization added silver diamine fluoride and glass ionomer cement to their lists of essential medicines, both the list for children and the list for adults, because they see that these work like medicines. These have the efficacy of other typical medicines, usually not 100% cure, but they make great headway into it. And so now for a medical system, for a healthcare system to be considered functional, they have to offer silver diamine fluoride and glass ionomer cement across the world. And there's no question, SDF is a medicine. This stands on the shoulders of the American Dental Association evidence-based practice guideline, as Jeanette mentioned, where they say clinicians are encouraged to prioritize the use of non-restorative treatments, SDF, based on effectiveness, safety, and feasibility. And in that guideline, which if you haven't read it yet, if we were practicing medicine, you have to follow the guidelines. For some reason in dentistry, we don't have to follow guidelines. We have a lot of freedom to practice outside of guidelines, but they say to prioritize this. And that, not that we need more evidence. We have enough evidence. Go prioritize this. It's time. And they also use the word clinicians. So again, getting back to that point of it's not only dentists that are doing this. There's no evidence that we need a dentist diagnosis first. You need to be careful. It's a medicine that has, it can sting, it can stain, but it works. And what we see is that this is the first line therapy for dental caries. And this seems to be supported strongly by the ADA. Again, if this were a specialty of medicine, everyone would be required to follow this. For some reason in dentistry, we don't. This is seen by the World Health Organization. Nothing in there says we need a diagnosis from dentists first. So if there's signs of caries, we can have medical personnel, we can have dental hygienists place SDF unless it is otherwise specifically forbidden. In accordance with this, we at CareQuest and with our collaborators, Elevate, and many other wonderful people around the country, worked hard to create, and thank you if you're on for your support. We had a lot of support letters from folks in public health dentistry in particular, and the Society of American Indian Dentists and the National Dental Association and others, to create a medical procedure code for treating cavities with silver diamine fluoride. And so, like I said, this goes live July 1st. So please help advocate, please help support, please help inform the use of this, the appropriate use of this medicine. What we see is that medical personnel diagnose dental caries much more commonly than dental personnel do. Dental personnel sort of implicitly diagnose. They say they see something, they treatment plan something. A class 2 restoration is not a diagnosis of a caries lesion. So it is very common for emergency room physicians, for geriatric physicians, for pediatricians to diagnose dental caries. It happens all the time. Probably about 100 times more frequently than dental personnel diagnosing dental caries. So this is typical, and now they have a tool to do something. So typical thing happens, somebody walks into the emergency room, emergency department with an abscess. Is SDF an effective treatment for a dental abscess? No. But if someone has a dental abscess and they're walking to an ED, how many other teeth are soon to be abscessed if they don't receive some kind of a treatment? How many of those could we avoid by having the medical personnel apply SDF to the other teeth during that visit when they're giving them the antibiotic and maybe doing an IND for them. As Jeanette said, there was this clinical trial called Carried Away, I actually spelled it wrong here, sorry, done by NYU, where they treated 3,000 kids. And the interesting thing to me, as I mentioned earlier, is that all the treatment was done by dental hygienists and nurses out in schools. And nothing bad happened. They were all okay. There were no huge complaints. Nobody lost their job. Everything was all right. No kids died. So everybody did okay there, which I think is pretty meaningful. And like Jeanette said, there are tremendous strengths and certainly limitations to SDF treatment for dental caries, but there's no evidence that a dentist doing it is any more effective than a hygienist doing it. And in terms of safety, we actually did an FDA safety trial of dental hygienists doing SDF in Head Starts versus placebo. We published this some years ago, in 2018, I think, and the outcomes were great. 72% caries arrest at 3 weeks. These are big cavitated caries lesions. These kids have 3+ lesions on average each. So there's strong evidence that this is safe for dental hygienists to do in the community without a dentist physically present, as a part of a cohesive medical system where, God forbid, if something happens, they can get, care just like anything else, and that the cavitated non-cleansable lesions that are unlikely to arrest will get to a dentist. And if there's an abscess, it gets to a dentist, absolutely. But this is a new wing of the oral health care system that seems to be tremendously effective. So effective, in fact, that Advantage Dental back in 2014, when we really first started getting this material, armed those same dental hygienists plus another 28 others with SDF and put them out into the schools and put them out into the Head Starts and put them out into the women, infant, children centers, and reduced the use of general anesthesia across their population of over 100,000 young kids with severe early childhood caries. Over 100,000 young kids, reduced the use of GA by 2/3. Now, there were other aspects to this program. They were using povidone iodine. Elevate just recently released a product on povidone iodine. They were using fluoride varnish. They were using glass ionomer sealants to treat and seal occlusals, pits and fissures. And probably most importantly, they were using case management to help get kids into care when they saw a cavitation that was in a proximal space. They prioritized them. When they saw an abscess, there was a higher level of priority. But so this is a part of the oral healthcare treatment system that didn't used to exist before Elevate introduced SDF. So thank you again. Studies like this have been replicated, as Jeanette said, to show that you can reduce the use of general anesthesia in a Medicaid serving dental practice, in a pediatric dental residency, and less emergencies while waiting for GA in another pediatric dental residency. So pretty big impacts of SDF. And then I wanted to share one more. Well, actually, let's talk just a little bit about the safety. So there's been some great work on the safety of SDF, and most of it focuses on the concern about fluoride. How much fluoride is in SDF? Are we going to overdose anyone? And so literally, if you just took a 2-liter bottle of fluoridated tap water, that's how much fluoride is in a full drop of silver diamine fluoride. That amount of fluoride is extremely safe, especially, if you think about that we're going to do this twice a year, 4 times a year, 5 times at most, maybe. It is an extremely tolerable amount of fluoride to our system. And by comparison to fluoride varnish, you have to have 7 drops of silver diamine fluoride to have the same amount of fluoride as in a standard 0.5 gram packet of fluoride varnish. There have been a few now, these are just 2 of them, pharmacokinetic studies of fluoride in the blood after SDF. So what that means is they take a blood sample, put SDF on the teeth, take a blood sample, and look at fluoride over 4 hours, over 24 hours. And what's provocative is that the fluoride levels don't increase. If you brush your teeth with fluoride toothpaste, you can see the fluoride 20 minutes later. If you put fluoride varnish on, you can see the fluoride an hour later. So this is really interesting that if you carefully apply silver diamine fluoride to the caries lesions directly, let it absorb, remove the excess, and move on, we are not seeing an increase in fluoride in the blood levels. And this might sound really wonky, nerdy science, like science stuff, but I have shown these to patients and to parents of young patients, and this has gotten them comfortable, anti-fluoridation parents, this has gotten them comfortable with silver diamine fluoride treatment, and I have done this pretty routinely. So I wanted to share that. Please use this. I wanted to talk about prevention a little bit. So as Jeanette mentioned, our colleagues at the AAPD have been really against prevention. And I will speak personally. This is not on behalf of Elevate. This is not on behalf of CareQuest. I do value the AAPD tremendously, but I do think that this particular stance is actually just trying to stop hygienists from placing it in the field, and that train has sailed. These are 9 clinical trials on using silver diamine fluoride for prevention. And if you see a bar in the panel for that trial, it means that there's a preventive effect as compared to a treatment or a placebo. Some of these trials have 500, 300, 800, 300, 300, 700 kids, okay, 20 kids, 50 kids. Compare this to anything that's typically done in pediatric dentistry, and the level of evidence here is higher. Is it 100%? No. Do we have clinical trials where it seems like there's no effect and we're scratching our heads? We do. But there's no reason to avoid using this for prevention when it seems very clearly to be more effective once a year to use silver diamine fluoride than 4 times a year to use fluoride varnish. So no one seems to be against this except for some political groups that don't want medical people to do fluoride varnish, that don't want hygienists out in the field doing anything, that don't want a tooth touched without a diagnosis from a dentist. Anyway, what have we learned from the published clinical trials on SDF for prevention in children? Overall, it seems to be about 60% prevention. There was one study that looked at, this is versus controls. So SDF treatment seems to prevent new lesions. So this is after 1.5 years, 2.5 years, 3 years, about 70% it seems. So the treatment of caries with SDF seems to prevent new lesions on nearby surfaces. That's pretty profound. There's a study here where they did once versus twice per year, and they did not see an effect. On average, these kids had 9 new cavities after a year, so pretty high disease rate population. And there was no difference between once versus twice per year, so maybe once per year is enough. And then there were some studies comparing to sealants. And in one study, the outcome was similar, a little better for sealants. In the other study, the glass ionomer sealant was quite a bit more effective. So in these studies, they calculated the cost efficacy, and they found that the preventive effect of SDF was 20 times more cost effective than glass ionomer sealants because of the time and material expense. So it's very cheap. And the last one, these small studies are pretty weird, so who knows? But to say that there's no evidence for safety is bonkers. So I wanted to share that a little. And that's something we've learned in the last 8, 9, 10 years. Just a little bit more here. Jeanette talked about the SMART treatment. We do this routinely now. Just wanted to show this cavitated E. If you have access to sound enamel or dentin circumferentially surrounding the lesion, it is a very typical success for us to paint SDF at one visit and then have another visit where we just put the glass ionomer in. You can simultaneously seal the teeth nearby for more preventive effect of the sealant. And like Jeanette said, this is a class 1 filling. That's what we bill it as. So this is typically done. We've extended this in other ways to use that same concept where we're using SDF as a first-line therapy and to harden the lesion. so that the lesion becomes like a cavity preparation to then place a restoration on. And we need to separate the visits between SDF and the restoration if you don't want your restoration to turn black. Physically, mechanically, the restoration will be fine if it's black, but so we've done this. This was a 22-month-old kiddo where you know, we were able to do 5 surface restorations on her 4 front teeth with no excavation, no needles, no sedation, just singing songs in mom's lap because all this stuff is so quick. So thank you, Dr. MacLean, for developing this smart forte strip crown technique. I really appreciate it. And now I want to close by talking a little bit about some studies that we've been doing at CareQuest Innovation Partners to validate the clinical and financial aspects of these interventions. We've really honed in on initial caries lesions, in part because there's such strong evidence for SDF in cavitated lesions. And as Jeanette said, I'd say like probably the biggest learning of all this is, for me, has been the idea of cleansability. I'm not talking about that here, but if you don't know that, go back and read your GV Black, where he talks about leaving the decayed material in the dentin where it is. Do not disturb it or attempt to remove it. But he does talk about making cavitated caries lesions in baby teeth, making them cleansable. And so if they're not cleansable, might not stop with SDF. If you can make them cleansable, bingo. If they already are cleansable, they'll probably stop with SDF. So that's the cavitated. Now we're going to focus on initial caries lesions, which can be radiographically as deep as the outer third of dentin, E1, E2, D1 lesions. So we developed, oh, right, and the ADA says we shouldn't be drilling these. How did I get my dental license? What was the key step in getting my dental license besides going to dental school? Drilling a D1 lesion. So I got my license by drilling a D1 lesion. The ATA says those are not cavitated, you shouldn't drill them. We have a mix-up here. So we at CareQuest have been diving into this. Now, the first thing that we did was we set up this huge study. And as of, I don't know, February of 2023, we had over 70,000 patients enrolled in over 92 clinics, across 8 states. And this is in collaboration with Advantage Dental Plus. And we're very grateful for their collaboration and in developing this study. The focus is diagnosing initial caries lesions and you know, making that on record in their charts. And then we have educated and performed some change management techniques to help teams apply, you know, learn to appropriately offer and then apply SDF, an intervention called P11-4, also known as Curadon, and a sealant where our focus is using glass ionomer over initial caries lesions. Just a little bit about these different treatments Jeanette mentioned earlier, but you know, can use it on initial lesions, cavitated lesions. Does it seem to be able to be used on all surfaces? Does it protect neighboring teeth? SDF checks all those boxes. And you know, does it taste bad? Yeah. Does it smell bad? Yeah. Does it stain caries lesions? Yeah. So we have been, you know, pursuing these other options as a complement to SDF for when we're in the aesthetic zone or when stain is a concern. So as I said, over 75,000 patients with diagnosed initial lesions, and about a third of those patients have been treated with SDF. We're about at 3,000 patients with Curadon and about 800 patients with sealants. I mean, tons of patients with sealants, but so more like a PRR, like the sealant is to treat the initial lesion. These, just for the retrospective portion of our study, so patients treated from, 2018 through 2020, through the end of 2020, basically, watching what happened to those initial caries lesions over the next 6 years. Sorry, 2016 is when it started. Mainly those were SDF. In those same patients, if they had a dental restoration, a class 1, 2, 3, basically 1, 2, or 3 surface restoration, we also track those. So the patient has an initial lesion diagnosed on one tooth, a different tooth has a class 1 or class 2 restoration. How long do these initial treatments last before they need another restoration, before they need an endodontic treatment or an extraction? And so what we see is that these treatments, these therapies, are non-inferior to dental restorations. In terms of the order overall across the entire ELMO study, retrospective and prospective, what we're seeing is that sealants seem to have the highest efficacy, and then SDF, and then Curadon, and then fillings. Very few smart fillings, I wouldn't really focus on that, but what we're seeing is that all of these treatments statistically, if we look at 3 years or 2 years, are non-inferior, so they're not worse than the outcome of dental restorations in this same patient population. And we're actually seeing superiority of dental sealants and SDF to restorations. So what does that mean? Well, so what? So what we're saying is that in a huge population across a wide swath of, what is it, 80% Medicaid, 20% commercial, permanent tooth initial lesions, including these D1s, we are seeing superior outcomes with SDF to restorations. So if you put SDF there, you actually, in our studies in Alabama, Oregon are the main states, but 6 other states also, Texas, Kentucky, Massachusetts, Florida, Idaho, Washington, I think I'm forgetting one. We're seeing superior outcomes using this as a treatment for initial lesions. Not a randomized study, but still. So from our perspective, this stuff is validated and ready to go. And what about money? I'll close with this, is that, can we ask this question? What about money? So these things are paying less than a restoration. So how can I make money off of this? You know, this is another thing for a payer to cover. How can I save money if I'm paying more? So we asked that question formally. We just posted this this work on a preprint server. I'll put that in the chat, and you can access it. And I would ask you to connect us to your payers in your network or that you work with, so that we can show them this work and that we've tailored this work that I'm about to show you, and we can tailor it to their plan and show them how much money they'll be saving and what appropriate rate they would be reimbursing based on their on your system. So we dove into this formally, again, just focused on initial caries lesions. So they could be saving a heck of a lot of money on operating room treatment for cavitated lesions. We didn't look at that. So what we did was this. We built a relatively comprehensive financial model of what happens if you have 1,000 initial caries lesions distributed across a bunch of patients, and you either get no treatment, restoration, a dental sealant, Curadon treatment, or SDF. And we built these 11 sort of idealized models, what we call scenarios, of these different treatment paradigms. We estimated that about 40% of initial caries lesions get restored currently. That's our current practice model. And so we have our initial treatment financial model, and then what we see is over the next 3 years, based on the clinical outcome data from the ELMO study that I showed you, what is the failure rate and the average cost of the failure rate. So you can apply the additional income to the clinics, additional payment to the from the payers, and the outcome for the patient. And we did this, you know, at the end of each year, using this large data set that we produce. First thing you got to do is figure out what's the appropriate financial reimbursement for these treatments. And so that's where we calculated the cost to the payer with the current practice estimate. We calculate the net profit to the clinic, and then you see where these things can change based on the reimbursement per tooth, how you can decrease payer cost, that's savings, and increase clinic net profits, and where the break-even points are there. So what we do is we take this to payers and we say, you know, you got to pay at least $10 a tooth for the practice to even break even to change their current practice. And same thing for the payers. They can't go over this amount if they want to save money. And it turns out over and over again, pretty much every single plan that we've seen, there's a sweet spot, this green area in the middle, and we just suggest the midpoint. Now, for this model, we're looking at Alabama Medicaid because 16 of our clinics are in Alabama from this system, and they have a fee-for-service model. And it turns out they're actually already reimbursing at $20 a tooth. Good on them. So things are already set up for the clinics to make more money and the payer to save money just on initial lesions. We calculated, after paying all the expenses, after paying the clinicians, what's the net profit per hour for chair time for the clinics if you go into these idealized scenarios. What we see is you get about 50 after paying overhead, after paying materials, after paying clinic staff, all that. The existing practice model has you at about $50 per hour of net profit. And what we see is that because these treatments can be done by dental hygienists, that's the model here, because they're so quick, they can be added onto a recare visit. We see that net profit per hour going up dramatically here. So it works out incredibly well for clinics. And then finally, what we do is we put this all together where you have that, you have clinic profit margin on this axis, you have payer savings on this axis, and you have how many teeth end up at the end of the 3 years without getting a filling, drill-free teeth. And it turns out that if you don't start off with a model where you're just drilling the initial lesion from the start, that doing these non-invasive therapies, because they have effectiveness to them, they will decrease the amount of teeth that need a filling. So it improves the health outcome for the patient. And in the green here, as you can see, there's these scenarios that save money for the payer and increase profit for the clinic. And we see this as being the answer going forward. So again, please connect us to folks in your network so that we can do this math for them to show them how they can save money based on the existing reimbursement and utilization in their system, so that we can help build a better future where, yeah, clinics want to make more money. Yeah, payers want to pay less money, but we can actually use this to cover more folks, improve access to care. And again, it's really all through the magic of SDF. So thanks so much. And that's the future. Future's now 10 years in.
All right, thank you guys both for just a great presentation. I'm going to take a quick minute here. We've been monitoring the questions throughout the talk, and this talk is clearly going to go beyond our 90-minute allotment. So therefore, we have changed this to be a 2-hour CE course. The CE certificate that you receive will reflect 2 hours of CE rather than the 1.5 hours like we had originally planned. If you need to leave at the 90-minute mark, we understand. This recording of this webinar and the Q&A session will be available online at elevateoralcare.com/elevatingcare in just a couple of weeks. So if you need to leave early, be sure to check out the recording once it is available. All right, so we've got quite a bit of questions here for you guys. I'm going to start off with this first one. There were a decent amount of questions coming in about application intervals, and this question kind of sums it up nicely here. It says that, do SDF application intervals differ for the different caries types, whether it's enamel caries, dentin caries, kids, adults, geriatric population, and root caries?
First of all, I would like to say that clearly you could see why we became pediatric dentists as we play with our finger puppets. Okay, sorry. But yes, this is one of the most common questions I get. And I mean, really the best way to sum it up is what I had mentioned during my portion of just that biannual reapplication, just as a good rule of thumb. However, it also depends on other factors specific to the patient, particularly what is their caries risk, because you might need to do more frequently, like every 3 months, for example. And then what is the surface? Is it an open lesion? Is it a proximal lesion? The depth of the lesion, et cetera, et cetera. So I would say that the more you utilize it, the better feel that you'll get for it. I mean, because almost 10 years ago, when I didn't really have much to go off of, there was sort of that trial and error where I had to get a comfort of how often or how I would approach things. So, it's not like there's one perfect 1 + 1 = 2 answer for this. Other than that, if you looked at the literature as a whole, that recurring theme of those biannual reapplications having the highest rates of arrest is important to remember. Now, that being said, I've had lesions like the case I posted yesterday of that little boy who, and it was in this presentation, the little boy where I did the front teeth. Those were open and cleansable. And after the 4th time I had applied them, which was over a 2-year period, so every 6 months, they got to the point where they were shiny and hard as a rock. And at that point, I went to just using fluoride varnish, like the full mouth fluoride varnish, and what I like to call active surveillance, where I didn't reapply the SDF, but had those gotten soft or something got larger or whatnot or sensitive, then I would have done some other form of treatment. But in his case, they just stayed shiny and hard because the habits contributing to those lesions no longer existed, and the hygiene improved, and they were arrested. So I didn't have to indefinitely apply to those particular teeth. Another example, like some very incipient lesions in permanent teeth. So like in my young adult patients, my teenagers, let's say they have an E1 and E2 lesion on a bite wing, like on a posterior tooth. My comfort level is like over a 2-year period, if I've applied it at least biannually, if I see that lesion remain stable, and in some cases I actually see that become more radiopaque because it's remineralized, again, I just go to my typical fluoride varnish and active surveillance. So if it were to change or become, dark again or cavitate or grow, then I have to move to doing something else. But I don't necessarily reapply those indefinitely. However, on primary teeth, you bet I put that on every 6 months if it's a proximal caries lesion on a primary molar, because think of how thin that enamel is. It's like your fingernail thickness, and the pulps are huge and closer to the outer surface of the tooth, so you can get into hot water real quick if you're not doing that close monitoring and reapplication on a primary tooth. Hopefully that helps.
Too, right? Cleansability. If you have a
Yes.
cavitation without cleansability, there was that Peter Vianos case I showed. You can win. You can arrest these lesions. It's just not going. It's probably not going to happen with once a year, twice a year application. But like Steve Duffin, Dr. Steve Duffin in Oregon, he developed this protocol. Remember, he was doing the 5 times in the first 6 months for these kids, and they avoided a lot of general anesthesia based on that.
Yes, but just
let's seal it everything, right? Hull crowns.
That helps too. But yeah, you had mentioned that we should chat about this on like the practicality of, because for sure, like having doing multiple, I think you at one point were trying to do like once a week, 3 times,
Yep.
I have folks come up to me at conferences and say, well, like, I don't know what, they say it's this many times, that many. So I say, dentistry is kind of like baking. We all have our special recipe. It's all delicious. You do what works for you. In my private practice, like for my patient population, my approach works for me. And, it can be very difficult to get the people even to come twice a year, and if I'm doing at least that twice a year, and trying to restore things that aren't cleansable or make them cleansable, I have had, as you can see, some nice long-term outcomes. So it's working.
Great, thank you guys. Okay, early in the life of silver diamine fluoride, light curing was a no, but there's recently been talk of a benefit to light curing. So what does the latest evidence say when it comes to light curing?
Makes a mess.
Do you want to stain your curing light and heat up the tooth and knock yourself out? You don't need to, and so like that, keep it simple. I really meant that. Like, why do you want to overcomplicate something if it's not necessary? And the irony of this is then you have the other crowd that is saying etch so it gets deeper. Like you have the paper that I think they're alluding to that suggested to light cure it was like to try to keep it from not getting too deep. So isn't that confusing for the users? Like, so I'm supposed to etch so it gets deeper, but wait, I'm now supposed to light cure it.
I feel like we have this shirt
Make it stop. Stop the insanity. Try, apply, and say goodbye. Next.
All right, easy enough. Okay, what is the evidence for root caries prevention using silver diamine fluoride?
That article on the cover of Jeanette would be a good start. I feel like I should open up my lecture again, but
Yeah.
anyhow, this will be archived and you could go to that thing. I'm sure.
Yeah, but there's three clinical trials that have been published on preventing root caries. By the time the JADA meta-analysis, that wonderful paper came out, there were 2 and it was very consistent. So if you have patients with high risk and exposed roots, it seems to work incredibly well for those folks. I'm trying to remember what the preventive fraction was. I don't know if they did that math for that paper. In the pediatric studies, we've seen about 60%. And I want to say, oh, right, there was a lot of heterogeneity in the clinical trials for older adults. They had some ambulatory, people who lived at home and were older, and they had some folks who were in nursing homes who were older, and the nursing homes, I think it was around 30% prevention, and the older adults, there was like 90% prevention. So there's just a huge range, probably depending on the disease factors in the patient, just like we were talking about for the treatment regimen. Depends on disease severity.
Okay, great. Can silver diamine fluoride be applied to desensitizing roots after flap raising, gingivectomy, and scaling and root planing?
Yeah, I would be careful to let the soft tissue have its initial healing and having your primary closure heal. So I would probably wait, personally, I would probably wait at least a week. But at that point, I don't see why you wouldn't. It's cleared by the FDA for hypersensitivity, for treating sensitivity. The clinical trials for that were done in root surfaces. So that works. If there's a caries lesion, it's probably going to stain. If not, then it'll work for hypersensitivity. There are multiple clinical studies now, placebo-controlled studies showing decrease in gingival inflammation, decrease in gingivitis. So again, as long as you have your primary healing, I wouldn't see any problems.
And just remember, we're pediatric dentists, so it's not like our wheelhouse of comfort.
Yeah, I was a periodontal assistant for 6 years.
Yeah, that's awesome. But the Texas A&M paper showed that gingival health improvement. We need to get a perio person that's a SDF user.
Yeah, Dr. Amala, you want?
That'd be a good lecture.
All right, Dr. Keeper, this one's for you. It said, based on the payment data that you provided, it appears that my state Medicaid plan is way under the rate you identified. Do you have any advice on how I can bring this to the attention of my state Medicaid's administrators? My state utilizes a third party for Medicaid.
Absolutely, yeah. Connect us to talk to the state dental director, the state Medicaid dental director, and the payer. I mean, we built this tool specifically for that reason. We can, get the reimbursement levels for a couple of treatments and show the range that would make this work. Note that our our cost-benefit analysis was only on initial lesions, so we're not even talking about how much cost savings there would be from general anesthesia for emergency department, sedation, all that stuff that Medicaid does pay for. Maybe not the sedation, but they pay for the rest, more advanced treatment. So this would really be just clearly cost savings. And as you pointed out, thank you, there are a lot of states that pay way below what would make sense. And so relative to other treatments, it would be clinics would be losing money to be applying this treatment that's recommended to be prioritized by the ADA. So yeah, folks should be reimbursing higher. I will just say personally, I've gone behind closed doors with some of the payers, and it is amazing that I would say in general, I haven't seen a lot of consistent sophistication around cost-benefit analyses around business cases. And so we are trying to create an academic environment around that. I think the reason is that it's all behind closed doors. There's no publications about any of this that we've seen. And if you look at where this field came from, this field of health finance, it really came from drugs being introduced to medicine and asking the question, okay, given the cost of goods and services and the cost of existing care and what the outcomes would be, what price should there be for this medicine, for this service of prescribing and dispensing this medicine. So this is the first time we've needed to or been able to do that in dentistry. And so again, we're trying to create an academic environment about it. So if you're interested in publishing stuff on this, please do. We're trying to form a community around this to bring oral health into overall health.
Great, thanks. All right, after SDF application, there's been some questions coming in about covering your SDF application with fluoride varnish, and does that improve the results?
I'm aware of at least one study, a Canadian paper, that showed a slightly higher arrest rate after 2 applications, where the papers that were included in AAPD and ADA's evidence-based clinical guidelines, those, like the highest arrest rate was 91% with a biannual application. But this particular Canadian paper had an arrest rate of 96%, and they were following with the coverage of putting fluoride varnish after. But again, it's not like you have to. There still is plenty of evidence to just use it as a standalone. I do cover my SDF applications with varnish, and there's a variety of reasons why I do that, which I could elaborate on if that is of interest. But I would say that there's a growing body of evidence to its impact on efficacy, but just certainly not as large as SDF on its own.
Yeah, it seems to help, right?
Well, it helps keep it where you put it, so I don't have kids walking away with accidental stain. It masks the taste, which is not fantastic, because I have had kids, especially ones that come from other offices where it wasn't isolated well, and they tasted it and had a bad experience, and we have to like literally be deceptive of what we're doing. Like there's one girl in particular, we have to use a code word that I am applying the strawberry, which is SDF, but she doesn't know because I don't let her taste it. What else? And really the idea, like none of us are original. Like I didn't think to do that. Initially, I was doing it based on the advice of Dr. Duffin, who published in CDA his DIY SDF, which was silver nitrate followed by fluoride varnish. And then prior to that, Graham Craig from Australia, the Burke study, he was covering his silver fluoride applications with a stoma adhesive wafer or base paste. And the thought process was creating this barrier to dissolution from saliva, which certainly is logical. So yeah, you don't have to. There's benefits if you do, and perhaps one of the benefits might be slightly better arrest rates.
Great, thank you.
Blatantly.
Okay. At the recent pediatric meeting in Orlando, there was a presentation on a large drug trial based in Michigan, New York, and Iowa. Will this cause SDF to become a drug? And if so, what impact might that have on the cost of silver diamine fluoride and third-party reimbursement for its use?
Oh, wow, that is a sophisticated.
Interesting.
Can I take that one, Jeanette?
Please do.
The outcomes have not been publicly released, so far as I know. However, they did stop the trial short because the outcomes were so impressive that the word on the street is that they couldn't continue ethically because there was such a strong effect that they had to stop the trial so that the folks in the placebo group could get access to this essential medicine. So I think it is safe to assume that the results were strongly positive and that therefore this pivotal phase 3 trial will be reported to the FDA and that the FDA within 90 days thereafter will call this a drug to treat dental caries, early childhood caries. That's going to be magnificent. One of the implications is that soon thereafter, there's a couple of steps. The CPT code, the medical procedure code, will be moved from a category 3 to a category 1, presumably. That's usually what happens. And then all medical plans that are in the marketplace, the Obamacare health marketplace, will be required to cover this. And Medicaid will be required to cover it. So right now, I think there's 40 out of 50 states that cover SDF at some rate. My understanding is that they'll all be required to cover it, and that a lot of the health plans that have dental coverage that are not Medicaid will also be required to cover it. Sorry, the health plans will be required to cover it as well. So that will be a huge movement, and perhaps the medical folks who are actually experts at doing cost-benefit analysis and pricing will step in and figure out how to guide folks appropriately. As I said, we just don't have that in our field previously. However, it also means that folks like Elevate, who produce silver diamine fluoride, will have a much higher level of reporting and scrutiny by the FDA. I mean, already the FDA can come and pull a bottle off their shelf and test it for the amount of silver and the pH and the fluoride and all that. But it'll be probably, I don't know, what is it, 5 times, 10 times as expensive for SDF to be produced in the United States. So presumably the cost is going to have to go up. That could be sorry, that was an exaggeration. Don't quote me on the 5 to 10 times.
Wait a second.
No, the FDA portion of producing it. So there's all the production of making it and all that, but the regulatory expense is going to be much higher for folks like Elevate when it becomes a drug to have that drug status, and then the price will go up marginally. So I don't know what the numbers will be. I think Elevate may have a better sense of that. Will the final price go up 20%, 30%? That would be my ballpark guess. I'm not an expert on this. But they're going to have to do more and harder work to keep it available as a drug.
Thank you. It's like watching facial expression there.
I'm trying to process, because I'm thinking maybe it'll be cheaper, because that's what also is so nice, is it's incredibly affordable, so I can keep my costs, especially when it wasn't covered, I could keep my costs accessible to people paying out of pocket for it. So that, yeah, sorry, I'll shut up.
I know we've done with this before, but as everyone and their mother starts offering it, maybe then through sort of commoditization, the price will come down through efficiencies of production. I don't know, but I think short term there's going to be added expense because of it being a drug for the manufacturers. Elevate, feel free to come in and correct me if I'm wrong, or just say pass.
Order some more Floramax toothpaste and varnish.
Okay, we'll move on to the next question here. There's some questions in about a two-step SDF product, and does that work just as well, and is that second step necessary and beneficial?
I'm sure they're asking about potassium iodide, right? And KI, adding KI. And I think I addressed that, so I don't know when they submitted the question, but I showed that slide where the problem when you add potassium iodide is it'll bind the silver and then you're rinsing it away. So it doesn't eliminate staining, it can reduce it. The problem is it also reduces efficacy, and in trials like looking at those teeth, they were more likely to become pulpily evolved after 12 months. So I don't recommend it. Does that sum it up?
All right. Does SDF alter the tooth biofilm, and how deep does it go?
So we've seen it go more than 2 millimeters deep into a dentin lesion, which is a lot for a tooth. So really it can go as far down as the lesion is, and it can go further than that. It alters so I did a bunch of the microbiology on this, the clinical microbiology, and it alters the microbiome in the big consistent way that it does this. If you ever used SDF on a patient that has a lot of plaque, is that it dramatically reduces the overall burden of plaque in the area. Steve Duffin has a famous, well, amongst our little group, famous case where there was a patient who, I think he had Parkinson's, and just wasn't able to hold a toothbrush anymore. And he started using SDF on the roots of this patient to treat and prevent caries lesions. And he came back for a regular visit. So he went to his house. He said, "Who's been brushing your teeth?" And nobody's been brushing his teeth. And it was just that presumably it was the silver embedded into the dentin that kept the bacteria, the microbes, from growing in that area. It was pretty profound. I've seen similar things. I would say if like there's a tiny little lesion, I wouldn't expect a huge effect. But if you have a caries lesion that absorbs a bunch of SDF, you're probably going to have a profound effect on reducing the microbes in and around that lesion. So we've seen it dramatically decrease. I took what was it, 2 teeth from each of 20 patients in one of the clinical trials that we did, placebo and treatment, and I didn't see a consistent shift. I was expecting to see like strep mutans and all its bad friends disappear, and I didn't see a consistent significant reduction or outgrowth of any particular bacteria, except there was a slight increase, a consistent slight increase in Lactobacillus reuteri. And that was really interesting because that's the only microbe I've seen in probiotic studies where they're putting a bacteria into your mouth that actually seems to prevent caries. So there was a study of like yogurt in older adults where they had a bunch of Lactobacillus reuteri, and 2 different studies in kids. And that's the only one. There's been a bunch of probiotic studies that had no effect, unfortunately, except for this one bug. So strep mutans seem to, at least in this one study we did, seem to naturally increase the abundance of this one bacteria that, if you put it in the mouth, also prevents caries. So seems like good things. We also took that, we looked at, the antibiotic resistance profile of these bugs, because bugs have these plasmids where they have anti-metal, antibacterial resistant genes in the same gene cassette, in the same plasmids. And so we're like, are they becoming resistant to metals? Is that going to make them resistant to antibiotics? Is that going to create a bad problem? And that did not shift at all in the studies that we did. It just seemed like it quieted down.
Thank you for making that point. I was going to suggest bringing that up because I think that could be, I don't know if that was their underlying concern, but I would imagine some people have that concern. And then it's also important to mention that there will always be bacteria. I think some people get confused. Like there was one particular publication was like, well, we found bacteria. Bacteria is everywhere. And, I like how you rebutted that by saying, but what was it doing? What was the bacteria? Yeah, you found bacteria underneath in the SDF layer, but what was it doing?
Not much. It's just staying quiet.
It's hanging out, chilling.
Right on.
All right, we're going to wrap it up with one final question here. There was a few questions that came in around the SMART technique. So to kind of sum up the few questions, what is the Silver Diamine Fluoride doing in the SMART technique that the glass ionomer can't do? They're saying if the glass ionomer is sealing the lesion, like in a Hall technique, is the SDF really necessary?
That's a great question. So as a pediatric dentist, what it's doing is that I have kids who I literally cannot even do a traumatic restorative treatment. Like they can't sit there for a 5-minute procedure, and I'm lucky maybe to get 60 seconds. So what it's doing is putting out the fire, and you can't do, let's say they have 20 caries lesion and they're 5 years old, I can't do 20 atraumatic restorative treatments in one setting or Hall technique unless they're doing general anesthesia. So it's enabling me to treat all of the lesions at once. So I think that first and foremost. And then I showed that slide of remember when I was giving the analogy of recycling? So it can remineralize portions of the dentin that perhaps maybe you would have mechanically been removing, doing a conventional preparation. Now, granted, you can leave that and just put glass ionomer and that will remineralize it too. So, my personal approach is if there's too much caries or the behavior isn't great, I will use SDF initially, or like if it's incipient caries. But if they can sit for occlusal art, I don't put SDF on all of my arts. I just put my equia, or I just put my glass ionomer. right? Or, you know, I don't put SDF under every hall crown that I do, but let's say I need to buy time due to the amount of caries or behavior or whatever the scenario is. I have smart hall crowns. I'm trying to think off of the top of my head, but I know there's papers that also show the benefit specifically to having the combination, or we call it combination therapy. But you know, you can have success with other atraumatic treatments without necessarily including the SDF, but the primary advantage is just how much you can treat in one setting, especially on someone who has, you know, pre-cooperative behavior, dental phobia, medically compromised, you know, elderly, frail, you name it. That would be the greatest advantage, I think.
Yeah, so the studies, there's 2 studies that I know of that they showed that you reduce the treatment time, the operative time, right? That was one of the advantages that both the studies found. It's just shorter. So if they're doing art, it was like, you know, 6 minutes instead of 9 minutes of total treatment time, including the SDF. So that's one. Another is the sort of implicit diagnostic advantage that, like Jeanette said earlier, like if you have a really deep lesion, you know, what are you going to do? Is it already abscessed? And it's a kid who can't tell you these things. You push on the tooth, you don't see an abscess, but was it just right at that tipping point? So very frequently what a lot of us do, we'll put SDF during that recare visit or the diagnostic visit, and then treatment plan the patient. And, you know, how did it go in the last 2 weeks since we saw you with this lesion that, is it in the pulp? I don't know, but it was asymptomatic. The day I examined it, we put SDF on, the lesion's hard, all the tissues look good, doesn't hurt when I push on the tooth or tap on the tooth. Let's put a restoration on that tooth. So it can help diagnostically. And I mean, I don't know, thank goodness I'm knocking on wood over here, you know, 10 times out of 10 for me, when I do that and put a restoration over it, then we're good to go. And I haven't had failures from that. I'm sure if I did as many teeth as Jeanette did, that you know, I probably would have some of those failing, but probably a lot less than if I hadn't done SDF first. The last reason I'll share is something Dr. John Picella calls integral strength. So we've had this conversation a bunch, you know, you have caries, like why would you ever excavate caries? Why would you treat with SDF to harden and do your chemical cavity preparation instead of your mechanical cavity preparation? And the idea there is that you have this soft carious dentin that it on its own doesn't support a restoration. But if you seal all the way around, the restoration is bearing on your cavitation surfaces, your cavitation margin. But underneath that, you know, and these teeth might be in there for a long time. They might be in there for the whole life of the patient. What does it look like? What is the strength of that? So if you treat with SDF first, then you're going to harden that and reinforce that whole soft carious dentin with silver, so that it actually becomes harder, and the mechanical properties seem more favorable than healthy dentin. And then you put a filling material over that. You have strength. You have integral strength of the tooth.
But to their point of specifically utilizing glass ionomer, I do have examples where just glass ionomer was used, and that because it does release fluoride and strontium, it will also hypermineralize. I have a really cool success but failure case that I need to share where a filling broke, but literally kind of like your SDF Proximal bite wing that you showed that had that the cool white halo. So this is where a filling chip, the class 2 filling chip, and it was just Equi, no SDF, and it was like literally hypermineralized because it is chemically bonding and it is releasing minerals into the tooth. So they both can help with remineralization. Now, if you were to just put resin on top of, then you have a problem.
I'll say for me, if I'm drilling a tooth, as a pediatric dentist, I'm almost never using SDF.
Yeah, same.
But I can avoid using the drill a heck of a lot because I use SDF. So for me,
a good way to describe it,
right? Now, if I was treating geriatric patients where, you know, the dentin is leathery and soft and hard and mushy and I don't know what it's going on, then I might be using SDF as a line.
A lot of colleagues will put it before cementing their crowns on permanent teeth. I have a lot of colleagues share that.
Yep. There you go. There's the nuance, the complexity, and the wonder of SDF.
Well, great. Thank you both for just a wonderful presentation this evening and for all of your time. And thank you to all of our attendees for joining and spending your Tuesday evening with us and for hanging on a bit longer than planned. To our guests, your 2-hour CE certificate will be emailed automatically within an hour or two, so be sure to check your spam folder if you don't initially see it. And then also follow us on Facebook and Instagram for links to new free CE events. The link that you see on the screen will give you access to our archived webinars, including this evening's webinar, which should be accessible in just a few short weeks. So please share this link with your staff and colleagues. And finally, on our Elevate Oral Care website, you will find buttons to request an informative CE-eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with you and your team to help you best serve your patients. So thank you and have a wonderful rest of the week, and we hope to see you on our next Elevating Care webinar in the middle of August. Have a great summer.
Thank you. Good night.
Thanks, Dr. MacLean. Thanks, Elevate.